There's been, over 2 decades of multiple bladder markers, molecular markers. Some are protein-based, some are cellular-based. And despite this, none of those have really emerged, any single marker, as a clear, definitive winner in guidelines, for example, in the management of bladder cancer. Having said that, though, the reason is because bladder cancer is a very heterogeneous type of cancer, and no single test probably could apply to all situations. So what we're finding is that it's probably going to be a combination of tests based on risk stratification that will ultimately prove to be the way to follow patients. And I'll give you an example. If you had low-risk bladder cancer, a non-invasive, low-grade, low-stage cancer, then your priorities are really how can we reduce the burden on the patient in follow-up? Can we eliminate some of the cystoscopy intervals? And what you're really trying to do is just convince the patient that you're not missing anything. If they have high-grade bladder cancer, which could be potentially lethal even in a non-invasive state, then you're really interested in a test that has a very high sensitivity, where if you were to miss it, it could be a big problem. So different markers perform differently, and so on one end, the low non-aggressive bladder cancer that's non-invasive, you really want specificity, and on the patients that have a really high-grade aggressive type of non-invasive cancer, you want sensitivity. So combining markers that do both would probably be the way to go, and have a panel based on the risk strata that you're following.